This conference will now be recorded.
All right, everybody, welcome to EMS Fellowship's Journal Club. We're going to see if we can present a few articles today. I think we're going to start off with Emerson Frank presenting an article. Then I'm going to jump back in and present second, and we'll have Chris Bianconi, our second-year emergency medicine resident, go ahead and present his article third. So we'll go ahead and get started if everybody's okay with that.
Emerson, you're on mute, I think.
Yes, I am. All right, let's go and try this again. It didn't work in the last one, but can you see, what do you guys see? Is it a blank screen or can you actually see my slides?
It's a white screen right now.
Oh, Jesus, this happened the last time too. Okay, hold on.
You have more than one screen up?
No, I'm on my iPad, and when I presented in the last meeting, I had the same issue. So I basically just have to broadcast my screen. So, all right. Now do you see it?
Yeah.
Okay. Okay, so my topic is the post-ROSC EKG, and does the timing of when you actually take that EKG or ECG matter? The actual article title was the association of timing of electrocardiogram acquisition after return of spontaneous circulation with coronary angiography findings in patients with out-of-hospital cardiac arrest. It's a mouthful, but again, does EKG timing matter when you get pulses back? This is me. Hopefully you guys know who I am by now. So PICO questions are what we're gonna go through. So what was the population of this study? So it was anybody that was 18 years and older, anybody that had an out-of-hospital cardiac arrest. They went to 3 different studies, or 3 different centers. So there was one in Italy, one in Switzerland, and one in Austria. They defined, well, I have this written incorrectly, but basically cardiac arrest was defined by absence of signs of circulation, and return of spontaneous circulation was defined as pulses were obtained. And then the EKG that was obtained afterwards, and an angiography was performed. So these are anything that had all of these criteria performed. These were included in the study, and they were done sequentially. So didn't matter Tuesday, Friday, whatever it was. If you were in cardiac arrest, out of the hospital, had ROSC, you were included in the study, except for these. So if it was a non-medical cardiac arrest, something I learned from the study is there's an actual criteria. So the 2014 Houston style was used for this. I think they've updated it in the past. But these are the non-medical causes of cardiac arrest. So a drug overdose, a choking, a drowning, a trauma, or electrocution. So these are also the minority, maybe not so much as drug overdose, but these are the minority of cases. The rest we see pretty regularly. So what was the intervention? They basically, because those systems have, not all of them are centralized healthcare, but they have very good record keeping. They use almost like the CARES registry of Italy and Switzerland to get pre-hospital data. And then for Austria, anybody that was transported to a medical University of Vienna hospital, we basically looked at the medical records because the pre-hospital data imported right into that. So they were able to get a lot of that data. And then they took the first EKG after return of spontaneous circulation. And I think I mentioned this on another slide, but I'll mention it now. If the first EKG had too much artifact, or they couldn't find it, it was never uploaded to the chart, they used the first one that they could find, as long as it was done before the patient went to the angio suite. So more of the method. So they used 2 cardiologists from each center. that were blinded to the entire case, and they basically looked at the EKG and was it a STEMI or was it not a STEMI? And it was based on the European guidelines of 2017, which are pretty similar. They've updated them since this study came out or was finished and being published, but they're pretty similar to ours. They use Scarbosa criteria with the Smith modification now. I don't think they did in 2017. And the only difference now is that they actually include Scarbosa criteria for pacemakers. But other than that, it's basically equivalent to what we use in America. They also used only isolated V1 through V3 ST depression as evidence of a posterior MI for their criteria, again, because they didn't require, it was retrospective study, so they didn't have posterior lead placement or right-sided leads or anything like that, so they had to go by this criteria. If either cardiologist disagreed, they used a third cardiologist that was blinded again as a tiebreaker, essentially. So based on this, so they, again, they took out-of-hospital cardiac arrest, they had ROSC, they got an EKG, and then they went to an angio suite at some point. So that was the timeline. When they looked at the angio suite, they were basically looking to see if they had, what blockage they had, if they got a stent, and how much disease there was, and as we'll talk about in a minute, if they correlated with the EKG or not. So what they did is they looked at the angiography, specifically the procedure note. If the procedure note was not informative or wasn't done, they had a blinded interventional cardiologist that independently looked at the images, and they used that data. They looked at if the patient had a stent or no stent and the percentage of blockage to any of the vessels. They defined significant stenosis as what's below, greater than 50% of the left main and greater or equal to 75% of all the others, which again is about on par from what I remember that our interventional cardiologists use in general in America for the ACC. Might be 70%, not 75, but again, this is in general relatively the same. They didn't have a comparison study. They basically were kind of compared together, but there was truly no true comparison. And it was a retrospective multi-center cohort study, which is good. So the main outcomes that they looked at was the disease that was in STEMI versus non-STEMI patients. And these are some demographics and some interesting statistics. I may have to pull up my notes, which is fine if you guys look at them. Anyway, I'll pull them up on my computer. So the primary outcome, STEMI versus non-STEMI. So they had 370 total cases that they looked at. 198 of them were defined as STEMI by those two cardiologists or a third tiebreaker. 80% of them are men, 75% were non-STEMIs, or of the non-STEMIs were men as well, which kind of goes along anecdotally with what we see in a general basis. Location, actually most were at home for the STEMIs, and there was a relative tie between home and in a public building for non-STEMIs. The rest were either at work or something else. EMS arrival time was shorter in the STEMI group. Witnessed by bystanders were relatively equal, actually. Sorry, I'm just trying to pull up my notes on another screen so that I can have some of my notes. Bystander CPR was about the same. Shockable rhythm was, 9% off, but relatively the same. And survival to discharge with neurologic outcome was, relatively the same, actually. The other things that are not on this is the median age for both were about 52. But as you can tell, I mean, your statistics are aside from your location, you can't really grab any other info from this. Aside from, kind of mimics what we see, I think. The other primary outcome that they had was what of your STEMIs actually needed a stent. So they and really what it meant for the ECG and if it was predictive. So these are the true primary outcomes. So the earlier the EKG was actually taken, the more likely they were false positive. And the way they looked at it is they defined it at 7 minutes and less, up to 33 minutes, and then more than 33 minutes. And they actually are going by some of the guidelines that have been published over the year as far as timing after ROSC. And in general, that time frame is about 8 minutes. What they saw is that the later, well, the time you took it mattered. So the positive predictive value for actually needing a stent and having a true STEMI, as you can see in your 8 to 33 minutes is the 85.5%. So they actually were very low positive, or not low, obviously 75% is still pretty high, but the lower positive predictive value, less than 7 minutes, and lower in greater than 33 minutes. So it looked like 8 to 33 minutes was the Goldilocks zone, quote unquote. The more important number was the specificity. So the later you took it, the more specific your EKG was for a true STEMI. And interesting stat is about 50% of the non-STEMIs still underwent stent placement. And this is about average. Most of the data shows about 40 to 60% of post cardiac arrest, return of spontaneous circulation ended up having a stent placed as well. So that goes along with the data. So they basically concluded at this point that the study was generalizable. So the author's conclusions was that a post-ROSC ECG STEMI, when you took it, had more, when it was a STEMI, more or less had to do with the flow during cardiac arrest, not necessarily that there was disease. So the earlier you took it, the more likely that you were getting artifact from a low flow state or a no flow state rather than a true disease, as noted by the more true negatives for the EKG at 8 minutes. They do recognize that this is, again, a retrospective study. It's got limitations, but the optimal timing needs to be determined. And you should look at serial EKGs. So they didn't mention it in the presentation, in the article, but they had better positive predictive value, better specificity the later that it was, which correlates with some of the things that they have. We'll talk about the quality checklist. So we do this in all of our studies to see how good of a study it really was. So was it a clearly focused issue? Yeah, you don't want to take everybody to the cath lab that has a STEMI if it's not a true STEMI. So, it focused a small portion of those patients, right? Is the timing appropriate? Did they use an appropriate method? I would argue yes. They took almost every cardiac arrest that had return of spontaneous circulation that went to angiography at 3 hospitals, and they looked at the timing of it, and they looked at if they got stents. Was the cohort recruited in an acceptable way? Yes, they were consecutive. I mentioned that before. Was the exposure accurately measured to minimize bias? They blinded the interventional cardiologist if they need them, and they blinded the cardiologists themselves. And because it was retrospective, none of the EMS providers knew that this was going to be the case. And the same goes for the outcome measurement. It was minimizing bias. I would argue yes. All the important co-founding factors, it's hard to see because they didn't mention it. I think that they did. They talk about how they looked at, the timing, the flow. They argue that there could be some flow differences. They didn't actually mention if they used what their data or their statistics came from the second EKG. So you could argue maybe that they had a certain proportion of the second EKG because the first one was either not found or bad artifact, and that could be skewing the data. So that might be something that they didn't really identify or talk about. But in general, I think all the other confounding factors were there, but we could have a discussion on that. Was there complete outcome data or follow-up data? Yes, they had discharge data. So they had a good proportion that were good neurologic outcome in both the stented STEMI group and the non-STEMI group. And how precise were the results? I would argue they were precise. They gave you specificity and positive predictive value. I do believe the results because there's a lot of patients that come in, you get a cardiac arrest, you get pulses, you rush to get that EKG, and you're like, well, that looks like a STEMI, but let me get it again in a minute, right? Like, we always try to rush to get our EKGs, and maybe we shouldn't. Can it be applied to the local population? I would say yes and no. So again, I didn't go into detail and do a whole demographics and epidemiology on Switzerland and Austria, but from my recollection, Switzerland is a little bit more of a homogeneous population. Italy is as well. So they didn't go into detail as far as demographics. Like, did they have a lot of African Americans? Did they have a lot of people with diabetes? They didn't go into that data. So it'd be nice to know more or less the specifics of that data and that demographics to see if it's truly generalizable. But yes, that's important, but I think that the ultimate takeaway from the study is the timing can be changed a little bit, or we should be a little bit more cognizant of the timing. I think that's still applicable to every population. And then, does it fit with other evidence? And it's not on this slide, but so there was actually a study, and it was on MRAP in November, and I think that it's interesting. So they actually looked at something similar, and they looked at out-of-hospital cardiac arrest and time to angiography and outcomes. And what they saw is, aside from STEMIs, the article didn't look specifically at STEMIs, but they talked about out-of-hospital cardiac arrest and when they should go to angiography. And the entire study and the data that it references that was historical looks at, well, if you stabilize them, treat what caused their cardiac arrest versus the people that went to the angio suite right away, they actually had similar outcomes. And the cardiology literature specifically argues that you should stabilize them, whether they need to be on pressors and intubated or the whole nine. They could wait a day or two to actually get stented if they need to be stented, and they could wait to get angiography done. Now, they didn't talk specifically about STEMIs, but there may be some data saying that STEMIs could wait too. I don't know that for sure. I still would not argue that, but one of the things that they do mention in both of these articles, this one that we're talking about now and the one that I referenced, is you need to talk to your cardiologist. So you get an EKG and serial EKGs, and it's a STEMI. You rule out hyperkalemia, you rule out all the other, metabolic infectious causes, rule out COVID, having a conversation with the cardiologist as far as whether they're a good candidate for emergent PTCA, or if they need to wait and they should be stabilized a little bit more, because they're going to have complications. So it's weighing of those complications. But going back to this slide, external validity, again, we talked about how they're a little bit more of a homogeneous group, and that's changing now in the 21st century. But we don't have enough of the demographic data to really understand if it's generalizable to Newark versus community versus New York City versus Florida or anything like that. So I would definitely use this data, but I don't know if it's generalizable to everybody. My conclusions are basically the same. We've kind of talked about this. So we should be getting serial EKGs. We should be waiting till about 8 minutes. Now, if you're on the road and you have, a 3-minute transport time, I would argue get the EKG when you get ROSC on the road. We'll repeat it in the ambulance bay, or in the ER, in the trauma bay, or the resuscitation bay, to see if it's still truly a STEMI. And I think that in most of the places that I work, we get an official, one of our EKGs before activating a cath lab for even your non-cardiac arrest STEMIs. And so serial EKGs are important. If you have an EMS EKG that says STEMI, you have your first EKG that says STEMI, you go to the cardiologist and go, listen, they're otherwise hemodynamically stable, or they're on a little low dose Levophed or whatever, they need to go to the cath lab, then you have more data points to show it. And then the bottom of the slide talks about what I just mentioned. Delayed angiography for non-STEMIs is probably appropriate. That's all I got.
Yeah, so there's some centers. In the back of my head, I want to say in Kentucky, but I'm not sure. And that's only because there's only 2 competing hospitals. And what they do is for every cardiac arrest, they put them on, they only have one EMS system, and they put everyone on a mechanical CPR device, and then you know, pre-hospital cardiac, and they bring them directly to the cath lab, because I also believe that there is that a cardiac arrest is a fatal stress. They're going to need a cath at some point. It can be delayed, but you know, having that that elevation may not be them, but a lot of the times it may be. And I do believe in activating the STEMI early, because you get the team together, you get a cath lab ready, because sometimes those logistical issues are the biggest issues, and then kind of let the cath team decide to cancel it or do whatever they need. But it's not the end of the world. So if you get Ross in the back of the ambulance at the ER door, bring them in versus getting the EKG. You know, you can get the EKG as you're rolling in, or the problem is all the artifact from being on the stretcher and moving. What do you guys think? If someone's talking, they're muted.
Hey, I just wanted to say thanks, Frank. Appreciate it. I like the fact that this study was actually done in a system that does have a very sturdy like medical record system in order to make your results very reproducible. I think it's really important. And I think I would, you know, I think that we can extrapolate some of this to work in the emergency department as well, as far as, you know, waiting the 8 minutes in order to get those best results. So I just want to say thanks.
Yeah, and with, you know, we're a little delayed, but with the HL7 implementation, we're gonna have a lot of the RWJ data that's gonna port in, and we have a huge system, right? Like we have hundreds of paramedics and you know, a few dozen paramedic trucks on the road on a daily basis, and a lot of the times, you know, a good proportion they come here. So once that port over is complete and we have the data, we definitely could do a study like this on our own and have a lot of demographic data. So if you look at the community area, they have a lot of, you know, older white people that have disease, and a lot of sick people. In the Newark area have a little bit more of like an urban area. So you can get a lot of data that's a little bit more generalizable to our country, and, you know, have outcome data, have pre-hospital data. And so this is definitely something we could replicate in the future.
All right, anybody else? Great. Chris, do you think that you're ready to step up next? Go ahead and give us yours.
Oh, sure, why not?
Sounds good. Let's go ahead and do that.
You just need to give you present, make you the presenter. There you go.
All right. Oh, I don't like that. All right, whatever. So this is my slide. This is my article, Extraglottic Airway Device Misplacement. This was a small center study that was done in New Mexico to evaluate how we are placing our mostly EMS, how we are placing our supra and retroglottic airway devices, our kind of secondary backups, or sometimes our primary airways out in the field and in the emergency room when intubation might be difficult or unobtainable. So what they were doing, what they looked at the PICO questions, they looked at deceased individuals, whether they were in the field or who made it to the emergency room, who had extraglottic or retroglottic airway placement as their end airway, you could call it, what was left within the patient. They had a group of about 470 that they looked at, and they excluded anybody who was intubated or did not have a postmortem CT. I didn't know that this was a thing, and it might be one here, but in New Mexico, they have a very large system where they do postmortem CTs quite frequently. So they're able to find quite a fairly large group of patients over 4 years to kind of create this novel system to evaluate airway placement. So what they wanted to do was create a classification system to look at how the airway is placed, where it is. Is it too small? Is it too big? Is it rotated? Is it kinked? Is there obstruction? As no such system had existed before. This is the first study of its kind that's using a postmortem CT to really truly evaluate exactly how the airway is placed. There's been studies in the past that have looked at end tidal volumes and various other parameters to ensure proper airway placement. However, this is the first of its kind to look at exactly where the airway is placed. And from there, they wanted to kind of just use this tool that they created to evaluate their patient population. There were no comparison groups. It was all just these patients. You could say there was a comparison amongst the different extra and retroglottic devices. However, we'll see that only one of them really had significant numbers. The rest were all very uncommon. The outcome, as I said, they wanted to create this placement classification system and evaluate it. Their conclusion was that they created this system and that they think they can use this to help evaluate how well we are placing systems. Just some background, they had 5 people, a radiologist, 2 emerge doctors, and 2 forensic pathologists, so 5 in total, who created this system based on their experience and based on other articles describing intubation placement with postmortem CT. And then they had 3 of those, one of the ED docs and the 2 forensic pathologists, who then graded each of these airway placements based on their own scale. This is what they came up with. There's 2 depths, and this is just for your supraglottic devices, your LMAs, iGels versus your retroglottics, the combi tube kind of deal. The size fits for both rotation, whether or it was greater than or less than 30 degrees of angulation, kinking, blockage, and then injury to the surrounding structures. They defined definitive misplacement as any D3 or D4 category, S3, S2, R2, K3, M3, or I3. So any one of those categories was classified as a severe displacement and one that would not get appropriate ventilation. And then they just kind of included the postmortem CT of what looks like an LMA and a combi tube, and these are just kind of just describing your ideal placements, your LMA, the laryngeal mask really sitting just perfectly on the larynx, and then your combi tube, you've got your esophageal and your pharyngeal balloon both inflated appropriately, and the port is lined up very, very well with the glottic opening there. So before we get to the results, the quality checklist, they focused on a clear issue. Yes, they did. They came out at the onset and kind of wanted to establish this new grading system. You could question quite a few things about the study as to whether they used an appropriate method and bias, because they really kind of just went off the beaten path and kind of started this new evaluation tool for extra and retroglottic airway device placement. So there is some room to be concerned for some bias. However, given that there's no other literature, you kind of got to look at it how it is. The cohort was recruited in an acceptable way. They did identify the important confounding factors. There's a couple things. There's not a whole lot known as to exactly who placed the device, whether it was placed by EMS, was it the basic, was it the paramedic, was it placed by the ED doc when they got there? There's not any data about that. They also admit to the fact that there is some limitation as to exactly how accurate this is, because all these postmortem CTs are performed off-site. So these bodies are bagged and transported. What happens to that device during transport is anybody's guess. So there is some limitation in that as well. There's possible, displacement or proper placement just by a simple nudge or a bump in the road that could, skew the results. The follow-up was enough. They got the CT, and that's as far as they need to take it. How precise are they? It's difficult to say. Again, this is a new method. I think there's going to have to be other trials if people are interested to look at exactly how well this kind of evaluates airway placement, and maybe kind of corroborate that with end tidal CO2 measurements. There's more work that can be done, but for now, this is what we have. I do believe with the results, I think they made a fairly a pretty good evaluation tool, and I think they were pretty thorough about it. Can they be applied to our local population? I would say so. I think the question being is, what is the difference between the EMS systems between New Jersey and New Mexico, and what level can people start placing these airway devices? I think that might be something to look into as to what the applicability might be. You know, we might have more experienced providers placing these, or they might have more experienced providers placing these that might kind of skew the results. And they do fit. There have been other studies, like I said, that show similar rate of other values that show proper airway placement, the most common being end titles. But again, this is a really first of its kind study, so it's hard to compare it to much else. The results, hopefully you guys can see this all right. So they've got really their demographics here. Majority of men and majority of LMAs placed. The median age was actually quite young, in the 40s, and the causes are listed here. Cardiovascular overdose being two of the most common, which can fit our general population as well. And then you have your Agile, King, Combutine, and Cobra, which really had very small numbers. So for the majority of the study, it focuses on the LMA, as they had more than 85% of the total devices placed. As far as total misplacement, definitive misplacement as defined earlier, there was a total of 49 in all groups for a rate of about 14.4%. So roughly 85% of these devices were placed in a manner in which, based on CT evaluation, should be appropriate for ventilation. Just kind of looking through there, some degree of displacement, sizes, people seem to overestimate rather than underestimate the size needed. There was very little rotation. Kinking, what was funny to me is there was only one minor kink, and there were eight major, the major kink being one that would cause definitive misplacement. And then blockage was seen in 23. The blockage, it's difficult to say whether the blockage, most of them were due to a large food bolus. Was this something that was already present in the airway? Was this something that happened after the arrest and the body lost tone and contents of the stomach were regurgitated up into the upper airway as they laid flat on transport? It's difficult to say, exactly how accurate this number is at the arrest, but this is what they have. And then the injury. There were some minor injuries, and there were 5 actually a couple that they show very impressive injuries that they showed with device misplacement. So for external validity and applicability, we really don't know much about the patient demographics, which, you could kind of say it's an arrest, who cares, but, we really don't know to say, what is the population like in New Mexico? Are there going to be, some kind of racial, ethnic, weight, height disparities that are going to make them easier or harder to get a extraglottic airway than it is our population. We also really don't know the level of provider that was doing this. Again, I think that's probably one of the biggest gaps in the study is, was it the basic, was it the medic, was it the doc, and is there any difference in between those skill levels as to how it was placed successfully? So that's something that could be looked into. And then the other big thing is there a big difference between EMS agencies as far as the level of practice, who's more prepared, who sees this more, who places these more, I think is something else that needs to, that could be looked at. But overall, I think we can, roughly apply this. The 85% seems to be consistent with other studies that had different evaluation methods, but, I think there's still a lot of work that can be done here. I think the overall take that I got from this is that, we spend a lot of time, at least in the emerge room, I'm learning more about it in the EMS field, but we spend a lot of time thinking about intubation, what blade, what size, stylets, bougies, video. We spend so much time, but we really don't spend any time discussing these supraglottic devices, which can be very significant help in the resuscitation. And as we'll see in the study, can go really wrong if you don't know what you're doing. So I think it kind of brings to light that we all should be trained on these devices. We should all ensure that we're placing these properly and don't end up with a couple of these stellar placements here. So this was a LMA that managed to, this was a misplacement 3 and a kink 3. As you can see, it's completely folded up in on itself, and it actually, it was compressing against the soft palate up here. There's another one that violates the soft palate and is, heading towards the cruciform plate. The final one, which was really impressive, was an esophageal perforation with a combi tube, and you can see kind of all the free air surrounding there and maybe diving down in the mediastinum. So these are not benign devices. These are things to take care and make sure you're placing it appropriately, make sure our medics are placing it appropriately. So I think this was a good study to kind of get us all thinking in this direction and give us some novel data as to how we can evaluate these.
Yeah, that is very impressive. If you look at figure B on the right, the hole in the middle right above the spinous process, not where the triangle is pointing. The triangle is actually pointing at whatever tube that they inserted, and next to it is the actual airway. And I believe that is the thyroid or cricoid cartilage that you see above it. And yes, that should not be there.
Yeah, bit of a poor form, and I get it. Arrests are crazy. I finally had like a good arrest that we could work, or a good recess that we could work in the field, and it's quite chaotic. So I understand that it is difficult to plate these calmly and efficiently, but it is something we really need to consider because there can be significant patient harm. And I think it's safe to say that these 3 patients, we're definitely not going to get ventilated appropriately. So you're kind of just throwing something in there with no effect to it.
Well, the only good thing is that when it is ineffective, we will see that the end-tidal CO2 will not be appropriate. So
right.
that's a good thing that our confirmation test will tell us if we use it. Just remember, any good test has to be used and interpreted appropriately in order for it to work. Anything else, Chris? Does anyone else want to chime in a little bit? I personally like the eye gels a lot, mostly because we don't have these problems like with the LMAs. I actually put in my first LMA on a real patient maybe 2 weeks ago. I put a lot of LMAs in fake patients and on practicals, but I never liked it because I felt that the balloon would fold the wrong way for me, and I could never get it to actually inflate properly. I got it in the patient. They ventilated fine. They had good end-tidal CO2, so that was fine. It actually worked. But for the longest time, it was intubate. With the combi tube, I never had issues with the combi tube. With the king tube, same thing. Never had problems with the king tube. It just went in. And the eye gel, there's nothing to be floppy with it. But I can see that in these studies, the damage that was done, I could see that happening if you're just forcing it down. Really, what you need to do is you need to lift the jaw up a little bit and just let it glide in appropriately. But that's the same thing for regular intubation. If you are taking that tube and just shoving it where you think it should go, you can make your own potential space, which we saw in that CT.
Head on. Well,
maybe slightly off topic, but during my emergency residency, we all did an anesthesia rotation, and I'm sure just about everybody does. It's one of the core rotations. Of course, the purpose of most anesthesia rotations is to get tubes, right? So everybody bounces from room to room looking to place endotracheal tubes. And at the institution I was at, there was a whole bunch of surgeries where they weren't going to tube for whatever reason, and there were a lot of LMAs bouncing around. And most of the emergency residents had very little interest in those rooms. And by accident almost, I ended up in a room once or twice and ended up putting the LMA in. And it was harder in person than I was expecting it to be. And, the nose flipped over or what have you. And it was like, kind of opened my eyes a little bit to, oh, hey, these aren't just completely idiot-proof devices. And so then, from then on for the rest of the rotation, if somebody was in a case that wasn't a tube, I still did that one as well before I bounced to the next room. And I ended up placing 20 or 30 LMAs in real patients, before surgery. And obviously most of them were ASA 1s. And I mean, they were very easy cases, but it was instructional, and I learned more than I thought I would. And I think this study is one example of that. And my experience in the anesthesia rotation was just LMAs. Combi tubes obviously have other mechanisms where they can cause damage and other things like that, king tubes, etc. But you know, this is probably the most instructional study I've seen on you know, some of the damage that can be created. And I think there's a general opinion in EMS that that these are really easy devices to place. I think that's generally the case. I think that they do require less skill than, you know, endotracheal intubation, but they're not completely idiot-proof, and they do require a little bit of assessment and a little bit of readjustment, even with the iGels, you know, which decrease the chance of the tip flipping and don't have the balloon to inflate, etc. But you know, one of the images shown, the device was just put in the back of the mouth and was never actually seated over the larynx at all. So, you know, again, they're not idiot-proof. So, yeah, I think so for all of our practices and everything that we do, things to think about, maybe you do actually need a little bit of hands-on experience with this. If you're going to treat this as your backup device, you actually need to know how to use it and have done it a few times instead of just thinking you're going to be fine, be able to jam it down there. And then the second piece of this from a medical direction and EMS standpoint is, you know, people are quite often going to iGels, LMAs, combi tubes, kings, because they feel that that they're a safer solution than intubation. And obviously the problem with intubation is goose in the tube. But I think clearly some other study needs to be done about where's the actual risk. People aren't doing post-mortem studies when ROSC isn't obtained. This is the first one that I've seen. And so I think it does kind of give us some pause a little bit here and say, hey, you know, maybe we need to understand this a little bit more. And this isn't quite as simple as we all thought it was. So.
Yeah, and that's why I like this article, because it was something different. You know, what I preach to my residents is that you need to practice your backups. You know, when we all move to video laryngoscopy, people basically say, oh, my backup will be direct. If you were in practice for 10, 20 years as an EM doc or a paramedic who did a bunch, hundreds and hundreds of directs, you know, that's a great backup. But if you're just a new learner, it's not a good backup. You know, I think I intubated direct for the first time in a while, maybe a year, and I was just like, holy crap, that was so tiny, because I'm so used to the high def screens now and the color and the light, you know. But then also as a learner, what I found is that people who learn on video and learn with these special blades that are high acute angles, they don't have proper technique. They're not lifting the jaw. They're not aligning all the different axes of the neck so that, you know, you have that clear shot through the vocal cords. And, you know, that's sort of by design, because those blades are designed so that you can get those acute angles. But when you have normal people who don't need it, now we're having poor technique. So, you know, I always teach, you know, have good technique so that when something goes wrong, you fall back on how you train.
All right, guys. Anybody else have any other comments? Norman, if you're okay with it, I'll go on to mine.
Yep.
Sounds good. All right. So let me switch things over here real quick. All right. So my article was whether head and thorax elevation post ROSC is beneficial in a porcine model. Here we go. All right. So the article was titled "Improving Post-Cardiac Arrest, Cerebral Perfusion Pressure by," ignore that 3, "by elevating the head and thorax" by Duhem et al. It was in Resuscitation 2020. So this is a pretty new article. That's me. I'm MB20. So our PICO questions, the population. So they had 9 Yorkshire farm pigs. They were 40 kilograms apiece. 6 of those 9 pigs ended up completing the study. So there wasn't really a whole lot of exclusion criteria. The only thing that was really excluded was the pigs that did not achieve ROSC and therefore did not end up entering the study arm of the study. So the intervention, basically what they were looking at is elevating the head and thorax after ROSC and seeing whether or not this improved cerebral perfusion pressure. That was their primary endpoint. The comparison was just compared to lying a patient flat after ROSC from a VFib cardiac arrest. So the outcomes, like I said, the primary outcome was the post-ROSC. They would do a head and thorax elevation and found that it resulted in statistically significantly higher cerebral perfusion pressure and lower intracranial pressure values, regardless of the duration of VFib or the CPR method, and we'll talk about that in a minute. The secondary outcome, ones they looked at were mean aortic pressure, right atrial pressure, intracranial pressure, coronary perfusion pressure, end-tidal CO2, and regional cerebral oximetry. And they did this by a couple ways. So they floated up basically a central catheter looking at the right aorta with a transducer. They also floated one into the femoral artery, up into the aorta. I'm sorry, one into the right atria, excuse me, which was measuring your venous right atrial pressure, and then one they floated up into the aorta at about the level of the diaphragm to look at aortic pressures. They put in a bolt to look at intracranial pressures and measured regional cerebral oximetry, basically looking at your perfusion that way. They looked at end-tidal CO2. So the conclusions that they had is that raising the head and thorax, that's not supposed to say the, it auto-corrected, that's actually your head and thorax elevation post-ROSC significantly increased the cerebral perfusion pressure and decreased the intracranial pressure, regardless of the method of CPR. So just real quick for our checklist, this is technically a randomized clinical trial, but a lot of the quality checklist stuff was a little wonky when it comes to its applicability. So the study population included or focused on those in the emergency department? No, because they were just using pigs. They were adequately randomized, so they ended up only having 6 pigs that were, made it through the completion of this study. So they were randomized, but they were just all 40-kilo pigs. They didn't really differentiate the pigs beyond that. The randomization process was not concealed because there was really no differences evaluated other than the fact that they were pigs. The patients were analyzed in the groups to which they were randomized. No, so they didn't do any further, they had a veterinarian that actually looked through the protocol, the study protocol, in order to make sure that it met the guidelines for actually doing animal studies. But beyond that, they didn't look at individual characteristics of the pigs as far as gender or age or any other sort of, factors. Oops, I went a little far. Give me 1 second. There we go. Sorry about that. So let's see. There wasn't any really ability to, account for selection bias or blinding. Wasn't really a thing. So all groups were treated equally except for the intervention. That is very true because, honestly, they just split them into 2 groups and then they euthanized them afterwards. So there was not much of a follow-up period. And then patient important outcomes were considered. So really, the preset parameters of the study was really the only outcomes that were looked at. There wasn't any other sort of like survival or neurologically intact sort of stuff because they were immediately euthanized. And the treatment effect was large enough and precise enough to be clinically significant. So yes and no, it was statistically significant. I think it's difficult to say the actual whether these results are clinically significant because this is just a porcine model. This is a very early study, and as far as I'm aware of, there's not an enormous amount of data out there to really have a good quantitative understanding of improvement in cerebral perfusion pressure and intracerebral pressure to show how much effect that would have on things that are clinically important, like survival to hospital discharge or neurologically intact survival. All right, so this study, the way that they did this, I think that the easiest way in order for me to explain kind of how they did this and all that is to just look at this first table. So basically what they did is they had them break into two protocols. So the first protocol, which was protocol A, relied upon some other previous studies that looked at basically heads up CPR and prolonged CPR. So they started this protocol A at essentially minus 30 minutes. And what they did is they put them into 7.5 minutes of a VFib arrest. And then they followed that with a prolonged period of CPR. Oh, I'm sorry, 38 minutes. So 7.5 minutes of VFib arrest, at which point they were trying to allude to this idea of waiting in a pre-hospital setting for EMS to arrive. And then they did this prolonged CPR, and they were using this CPR that they talked a lot about here in the beginning, which was the active compression decompression CPR plus impedance threshold device. So for those of you or anybody that's unfamiliar, that is CPR that is using a suction device on a cylinder that essentially helps to not only gauge the depth of compressions and the adequacy of compressions, but it also suctions to the chest and actually pulls on the chest in order to help with decompression of that chest wall for every compression. And then this impedance threshold device essentially is they intubated all these pigs. And so this impedance threshold device prevents the passive inhalation of air during every decompressive cycle. And therefore, what that does is that creates a lot of negative pressure within the thoracic cavity that is proposed to actually bring more blood flow to the heart. So it actually is increasing your venous return, and with the idea that by increasing that venous return and you are then improving your perfusion overall. So they did this prolonged phase of CPR, at which point they gave them amiodarone and they give them defibrillations, 200 millivolts, until they achieved ROSC. There was some intervention using epinephrine. Once they achieved ROSC, in order to achieve a MAP greater than 65, and they showed that through the data that I believe 3 pigs were given epi. And those 3 pigs, there was no statistically significant difference in a lot of the measurements that they took. So it ended up being kind of a non sequitur. But after ROSC, in the group A, what they did is for 10 minutes, they brought up the head of the, I guess, resuscitation table. They called it a customized elevation device, CPR device. So it essentially raised the angle up to I want to say 7.5 and 20 centimeters off the level.
So there's actually a commercial device that does that, and it inflates basically a balloon, kind of like a car jack,
Yep.
used for a rescue, and it's actually designed from that, and it gives you that angle.
Yeah, absolutely. And then, so after 10 minutes of having them in this head up position, then they began having cycles of like flat, and then 5 minutes of head up, and 5 minutes of flat, and 5 minutes of head up. And so they did that for a total of 30 minutes there for resuscitation, taking all the measurements that are here on the right. And then, so protocol B, it gets a little weird. So their CPR itself was different, and also in protocol B, they broke them up into two arms. And so their CPR, what they did is they only did 6 minutes of VFib arrest, and then they did just standard flat CPR for 6 minutes, at which point then they defibrillated and gave AMI and achieved ROSC. And then the treatment arms that they split them into is one arm they laid flat for 10 minutes, and the other arm they then raised the head up to kind of simulate the same as the protocol A sort of results, and then they basically alternated. So one of them, the flat would go up and the up would go down. So basically your two arms then alternated as far as flat and elevated. So this showed a couple things I wanted to point out. Of all of the measurements that they got, the only statistically significant differences were the actual decrease in intracranial pressure and an increase in their cerebral perfusion pressure. And their results were the same for your protocol A or protocol B. And so things that I have kind of alluded to is the fact that, first of all, even your study arm, like the intervention arm, they still had this elevation and flat period. I should say what would be considered, I guess, the control arm, where the pigs were laid flat to begin with, and the CPR was done flat. They even got elevation. So there's, I think, a pretty decent risk of confounding here, because even if your control arm, which is the flat CPR on a flat surface, that's level, if you're then elevating them at the end of your study arm, that's a little unusual. The other thing is the differences in the CPR. I know that they did have like a control that was flat and then elevated, and also another one that was elevated at the beginning here. But it seems like this kind of heterogeneity when it comes to the way that the CPR was done, like why 7.5 minutes being in VFib instead of, and 6 minutes in the other one? Why, a couple other things with this. This was kind of an unusual sort of deal. And I wanted to show you their key results here. So these are really the relevant tables. If you look, your protocol A and protocol Bs are listed here. These are the ones that are relevant, showing that basically your cerebral perfusion pressure was statistically significant between the study arms. So there was an improvement there. There was also a decrease in intracranial pressures. And the idea with that is I don't know if I really made this clear, but with decreased intracranial pressures, the idea is that with an improvement in venous drainage from the cranium, then you are more likely, in order to improve actual blood flow to the cranium, in order to fill that relative, vacuum, so to speak. Other measurements, like all the other measurements, go back here. If you look, every other measurement that they had was not statistically significant amongst any of the control arms. So aortic pressures, right atrial pressures, they were all the same between the study arms, not statistically significant. And then the other strange thing is they measured this cerebral oximetry to look for like regional perfusion, but in the study paper they said that they lacked the supplies in order to measure this in their protocol B study arm, and I thought that was a little unusual, to where they talk about this as being one of their secondary deals, but then they don't actually have the supplies, and they did not go ahead and complete the appropriate data gathering in order to finish that portion of the study. I don't know why you would leave it in. The other important thing that I noted about this paper is that it's really important to know the principal investigator is Dr. Lurie. They're like, oh, nobody has any financial conflict, oh, except for our PI, who develops multiple resuscitation devices. He is the co-founder of Advanced CPR Solutions, a business entity that develops novel resuscitation technologies, including head-up CPR devices. So this is essentially a study in resuscitation that is a industry sponsored study. So and then for the external validity and applicability, this is a porcine model study, the very small sample size with a very single non-patient centered sort of measured, outcome. And so these studies are not meant to change your practice. These are just to stand as a springboard for further research. And there is some concerning sources of bias and confounders within the study. So that's what I got.
All right. So we touched on a lot of things that are very hot topics right now, and these are like changes that are like monumental. This is actually a follow-up study to Paul Pepe's study back in, I think it was published in 2019. No, actually, I feel like it's much earlier than that. Maybe it was 2018. But this was published in Critical Care Medicine. The paper is entitled Confirming the Clinical Safety and Feasibility of a Bundled Methodology to Improve Cardiopulmonary Resuscitation Involving a Head-Up, Torso-Up Chest Compression Technique. At that time, he reported basically all these similar findings, but he also wanted to say, wait, we need to do more research. Let's not jump to doing all this and spending billions and billions of dollars changing the AHA recommendations. Let's actually see if this works, because we've had problems in the past where we've done that, where we're like, oh, this is the hot new thing. Let's pass it through the guidelines. Let's push it out. Let's push it out. We're going to save all these people. And then we end up, well, it didn't really make that big of a difference, but we just spent billions and billions of healthcare dollars for no reason. So that's sort of the thing. After this, if you actually look at the paper, at that time, they did not have this fancy balloon device, which I'm pretty sure the principal investigator of this article is the one who developed it. It looks like an airbag. They just took either some sort of Pelican-like case, a hard instrument case, and put it underneath a scoop stretcher to give them that angle. And they put them on the mechanical device. The other thing with the mechanical device that you were talking about with the suction device, the funny story with that is it was developed because I believe either the creator or someone involved in the creation of it resuscitated a family member using a plunger from the bathroom. Because that's exactly what it looks like. If you look at the Lucas, it's the same thing. It looks like a freaking plunger, because that's exactly what it's doing. It's doing the same thing. It's a very simple device. And it's just giving you that suction. And like there's so many things that we're doing with cardiac arrest research that is exactly this stuff. I don't know why they chose to publish it in Critical Care Medicine. I believe it was mostly because they wanted to have a higher impact. And perhaps they weren't able to get into some of the other journals that are even higher impact. But Paul Pepe is one of the big names in EMS, and he was the one who he was the first author on this paper, and it was published March 2019. But I remember talking about this well before this happened, and most likely he presented it at NAMSP, and that's why I saw it before it even was published. And so that is actually in the folder for new fellows. If you did not get that folder, let me know and I'll share that folder with you, because I'm actually sending it to the new fellows, and I'll just CC you guys as well.
Yeah, and Paul Pepe was one of the actual people listed on this article. The other interesting thing is they didn't talk specifically about the active compression decompression plus impedance threshold device CPR. So I did do a little bit of looking into it, and I did read some of those earlier articles, and it does look like that does have some interesting promise. Like it does seem that was yeah, definitely something to look into and to really be aware of. I'm glad I read this article because although this is maybe a very early article when it comes to some research, it actually stimulated me to look into some more potential options coming down the pike.
Yeah, these are practice changing things. But again, we want to make sure that it's actually going to make a difference.
Yeah. All right.
Anything else you want to add? All right, so this concludes Journal Club, EMS Journal Club for this week. We're gonna be trying to get out the schedule going forward up until June, with all the dates. It's always going to be Wednesday at 12 o'clock, and the date is almost approximately every 3 to 4 weeks. But we're gonna have the actual dates for you guys coming out and published. And then starting in July of this year, we should have the dates for the entire year out ahead of time. So it makes it easier for everyone to schedule. So, check us out on Facebook, check out the website, www.emsfellowship.com. And